the session. Today is something which we were really looking forward to have a discussion and to learn. And today we have three eminent faculty to deal with the topic that Rajlakshmi was mentioning. Today we have Dr. Ross Taylor, Sister Jo, and Dr. Rashki Mani. So I'll introduce each and every one of them. I feel so much of pleasure in inviting three of you to the session, especially after the discussion that we had last time. That I know that this is going to be an interesting discussion among the participants also. Dr. Ross is a palliative care physician for over 30 years, and she has experience in working in a hospital as well as in community. She is involved in teaching widely in UK and internationally, and most of you might be familiar with the name from the Lancet Commission on Value of Death. So she was involved in that great work in the Lancet Commission. Sister Jo is a nurse consultant. Again, she has 30 years of experience in palliative nursing and teaching. And she's an expert in medical ethics and has a special interest in creative approaches to palliative care. It's very rare, Jo, that in India, we rarely get nurses to come up and lead many topics. So I really will take this home to my own nurses who are really willing to come up, and hopefully we'll be working together to empower nurses in India to do such creative teaching. And Dr. R.K. Mani is a very familiar person for most of us, but I'll introduce him. He's a CEO and chairman, Critical Care, Pulmonology and Sleep Medicine, Nayati Medicity and Nayati Group of Hospitals. He's a former president of ISCCM, that is Indian Society of Critical Care Medicine, and chairman of Ethics Committee that formulated, we all know the guidelines of end-of-life care and palliative care. So you might be very familiar for most of them, because most of them are working in palliative care for the last so many years. So welcome, a hearty welcome to three of you for today's session. Really looking forward for wonderful discussion and experience sharing from you as well as from all the other participants in the group. We can move on to the session right now.
Okay, hello everybody, and thank you very much for your lovely introduction of us all. I'm delighted as a nurse to be participating in something which I hope will be at very least a little bit of food for thought and an enjoyable few hours. So the topic that Dr. Roz and I have been asked to look at really through the ethical lens is this really hot potato withdrawing and withholding treatment. And right from the outset, what I think that the two of us want to convey to you is think about the language, and we're thinking about the language of considering appropriate options. And as this presentation goes on, you will see why we think that is possibly a better way to describe it. Sorry, I'm just that's it. Just having a problem turning over my next screen, my next slide. So what we're going to do in a short period of time that we're together is don't groan. We're going to just have a little look. I've referred to it as bite-size ethics. For those of you who are salient ethicists, and I know I'm amongst worthy colleagues in India in this respect, we could spend many weeks debating withdrawing and holding from an ethical perspective, but don't worry, I'm not going to do that. I'm literally just going to give you the kind of the absolute top line here, and hopefully disabuse just a little bit of confusion that there may be. Then Dr. Roz is going to do a case study, and then I will, and then we'll finish off with I hope a few considerations for you all. I think really this slide, which I know is a very old quote now, Peter Singer, who is a utilitarian ethicist. I think he's a guy who is out and about quite a lot internationally. And although not everybody would probably espouse to all of his thinking in terms of ethics, I do think that sometimes he speaks a huge amount of sense, and particularly this slide, when he conjures so much up with this. Technology creates an imperative. If we can do it, we will do it. Ethics asks, we can do it, but should we do it? I don't know about you, but that really does sum it up for me, that we are now working, goodness, in the time that I've been nursing, as as I said, for 30 years. If I think of the unbelievable technological advances and the excitement and the incredible things that are now achievable from a medical perspective in that time, it is actually quite mind-blowing. But of course, there does come to the time when we have to think about what are the outcomes? What is the good in what we're doing? Have we stopped and thought about the person to whom these potential interventions are taking place to? And is it always the right thing? And again, this is a conversation that we could be having for many hours, and we think particularly of babies who are born prematurely, and there's so much ethical nuance in so much of what we do. But I would also suggest that in palliative care at the other end of life, there is a lot that we need to stop and think about before launching in. So I hope that is a useful quote for you as we move through this presentation. Now, as I say, bite-sized ethics. I think that there are and I'm delighted that now internationally many medical students actually follow quite a lot of modules into medical ethics, bioethics, and I would suggest that for all of us, nurses, physios, OTs, doctors, surgeons, all manner of the multidisciplinary team really should be salient in ethical thinking. Because I would argue that every decision, everything that we do by that bedside, caring for people, is of ethical relevance. And when we're thinking about how do we work out when there is a big dilemma in front of us, how do we know what is the right course of action? Well, we hope that morality, we hope that intuition, we hope that the human shared common good will form the bedrock of our decision-making processes. And of course, key to it all is around communication with the patient themselves and of course their loved ones and their family. But I do think the 4 pillars of ethics are useful as just a bit of an aid memoir about when we're teasing out a dilemma, and this dilemma could be, manifest, about what it is that we are trying to get to the bottom of how are we going to nail this really. And to think of these pillars, otherwise known as the 4 principles or principalism, as every dilemma, let's think about the person's autonomy. Now, some people would suggest that autonomy is the principle that should trump all others. And certainly in the modern Western world, this concept of one's rights and one's autonomy and empowerment is really very, very considerable. But it does come with its own issues. So one person's autonomy and their rights might well be a conflict upon other people's. Then the next one is the word that is difficult to spell, beneficence. And beneficence is the promotion of good. So when we're looking at a dilemma, where is the good? Where is the human good? And the non-maleficence, another difficult one to spell, where is the harm and how do we mitigate against that harm? If you think of the medical mantra of medicine to do no harm, that's really something that we need to consider at the forefront of our decisions. And then finally, the concept of justice, not only considered in terms of obviously lawful practice, that everything that we do must indeed be lawful, but also the very important and hugely growing in, I would say, importance at present, is that around distributive justice. The concept of, do we invest hugely in one area of medicine and intervention at the expense of another? And how do we make sure that things are as just and fair as they possibly can be? So as I say, that was kind of ethical thinking in a bit of a nutshell. But if we're now thinking of our subject, our theme this afternoon, that of withdrawing and withholding treatment. As I said to you just at the beginning, Dr. Ros and I would probably suggest that that terminology itself can be difficult. It has a negative connotation. Is there a difference? Do you feel that there is something more nuanced about withholding something, i.e. never starting it, a treatment, or once something has started it, actually the physical withdrawal of it? Now, there has been many debates around whether the feeling of withdrawing something feels more difficult, more brutal than never starting it in the first place. But from an ethical perspective, and indeed, as this quote says, from a legal perspective in the UK, and I suspect elsewhere as well, there is no moral and legal difference between whether you never start something or whether once it's started and deemed to be not in the patient's best interests, deemed to be that word that maybe is less popular now, but still easily understood, but that word of futile. So the moral difference myth is that the old argument that actually withdrawing feels a bit more morally and laboured and more difficult than never starting something in the first place is now really understood that that's mythical, that there is no moral difference between withdrawing and withholding. Because actually the most important concept here, key to all of this, is what was the intention behind either the action or the omission. It is the intention and it is the consequence of that which makes the ethical relevance. So I hope that makes sense as we're going forward when we're talking about withdrawing and withholding treatment. And Ros and I are not going to be discussing ventilation, intensive care type of withdrawing or indeed withholding, but we're going to, I hope, describe in our case studies to everyday, so to speak, occurrences in the palliative care world, which are involved with these really important decisions of whether things should be started or indeed withdrawn. Just to sum up my bit really, I think although I have said that there is this clear understanding, both in the eyes of the law and from an ethical perspective, that there is no moral difference, I do think that it is important to emphasize, however, that for some people, so that may be health professionals, there is a difference. Some people feel that one is much more nuanced and more difficult to be involved with than another. So I'll just read this quote. And this is by an ethicist called Cousset, who wrote, "That is not to say, however, that everyone shares the view that withdrawing and withholding are morally equivalent, or that psychologically the two are equivalent, either for family members or for members of the treating team. Some people feel there is a significant difference in the message conveyed by a decision not to start or restart, as opposed to withdrawing treatment. There can be an impression attached to a decision to withdraw treatment that can be interpreted as abandonment or giving up on the patient." And you can see from that language that that's heavy and burdensome language. And that's why this type of presentation is so incredibly important, so that people have an opportunity to think about what it is they think about this stuff, what is their moral position, and to perhaps start to make sense of some of the real life, some of the clinical cases that they may well have been involved with in the past, or indeed in our future. And just before I hand over to Ros, I think it would be wrong to do a session on withdrawing and withholding treatment without a nod to the concept of the sanctity of human life. Now, I know that the term the sanctity of human life may feel as though it has some kind of religious connotation. And indeed, for some Judeo-Christian religions, the concept of the sanctity of life may well be the bedrock of certain faiths. But that actually is not really from the perspective of my presentation where I'm coming from. I am indeed, though, coming from the concept that actually human life is exactly that. It is, every human life is one. And I hope that all of you will agree with that. All of us who are health professionals will agree with that, that is what we aspire to keep at the absolute forefront of our practice, that every body matters, every human being's experience in their suffering, in their dying, in their lived experience is important and to be dignified. So that's what I mean. But actually what I mean by this slide is that in palliative care, and maybe one of the most important and difficult things that sometimes we have to help others accept, is the inevitability of death, and that actually part of the sanctity of human life is also an attempt to make the inevitability of death as dignified and good as it could be. And that actually just longevity in life, by keeping alive, potentially officiously, although that's an old-fashioned word now, but keeping alive through extreme medical intervention at the expense of quality of life, is problematic. And for many people who I look after, I would suggest that that is very much a key to their desires, is not to be either felt to be a burden to others or indeed to themselves. So I hope that's just given you a little bit of a start to our session. I'm now going to hand over to you, Ros. I think I'll put myself on mute. So as we're going forward, rather than the expression withdrawing, withholding treatment, which we have suggested has potentially this negative connotation, we're thinking about when people have to make appropriate options according to where they find themselves in their illnesses. Ros, shall I hand over to you now?
Yes, thank you, Jo. Thank you for a wonderful summary of ethics that we hope all of our colleagues, nurses, doctors, therapists understand as a basis for decision making. So I wonder if you could move on to the next slide, Jo. I don't think I can do that from here. And yes, so Jo's already mentioned language, and I think the word withhold sounds a bit cruel. When we withhold things from children, we're usually doing it for their own good, but it does sound cruel, and I prefer to think about thoughtful medicine. And one of my worries is that medicine is becoming less thoughtful because of all the things we can do but maybe shouldn't do, or the things we could do. So there are books written on thoughtful medicine. In Scotland, they talk about slow medicine. And I think it's about thinking about the person at the center who you are looking after. So next slide, please. And the person that we really revere in the UK, and I hope you do too, is Atul Gawande, an Asian American surgeon who I'm sure many of you know. I know his book has been translated into many, many languages. But as a surgeon, it's quite extraordinary that he has written a book reflecting on his career and his own family, and has begun to think and help us with a framework to look at decision-making in medicine. And I use, and I teach his framework to all of the nurses and doctors that we work with. And these 5 questions will get you to the right place often with your patients. So just to quickly run through, and I'm sure many of you are familiar with these questions. What's the understanding of where you are with your illness? And that immediately tells us whether somebody thinks they're going to die in a few weeks or they're going to live for 10 years when we know that they're not. So what's the understanding of where you are? And what are your fears and worries about the future? Often it's about leaving family. Often it's about dying in pain. Often it's about dying. But knowing people's fears and worries helps us to direct care more appropriately. And then perhaps the most important question that we certainly ask in the hospice where I work, what are your goals and priorities? And the best way to ask this question is, if you were feeling better, what would you be doing? And we're going to illustrate some of these questions, Joe and I, with two brief cases. So the next question, which was probably unique to Atul Gawande, and it's about what would you like to trade? So what's unacceptable? What outcomes are acceptable? What are you willing to sacrifice? And then lastly, what would a good day look like? Which is quite an uplifting question, because it helps the patient to visualize, what if my pain was better? What if I had more breath? What would a good day look like? So these 5 questions help you think in a more ethical way. So if we move on, Joe. So one of the questions that's become very popular in medicine, certainly in the West, we no longer ask, what's the matter with you? We ask, what matters to you? Which is back to those goals of care. What matters to you? Is it that you want to live till your next birthday? Is it that you want to see your son graduate from university? Is it that you want to wait for a baby to be born? Or is it just that you want to be with your family more, which is probably the goal that we hear most often. But I think what we are now training our young doctors to do in the hospice is to go back to the medical history. What we see in our acute hospitals is that people come into hospital and they go straight to the scanner. There's a loss of that medical history of where that patient's life, their life story, what mattered to them when they were well, what matters to them now, and who matters to them. So if we move on, Joe, thanks. So just a few brief words about the concept of advanced care planning. It's certainly advanced care planning. The term is used a lot. I'm not sure how much it's used in India, but this is about thinking ahead, sharing your future wishes with your family and friends so that if you become incapacitated, somebody knows what your wishes might be. But even if you're not incapacitated, just talking about the future, about what you would like to happen, where you would like to be cared for, who you would like to care for you, is really important. And it's like planning a holiday. If you know where you're going and where you want to stay, it's more likely to happen than if you haven't had that conversation. So talking about the future. Next slide. Thank you. And in the UK, we can document what you do want to happen, but it's not legally binding. As I've said, the conversations just help the right things to happen. They often are written down in a document called an advance statement, and it just helps all the health professionals and your family to know that a few months ago, this is what you said, and this is what your wishes are. We can, in the UK, complete something called an advance decision to refuse treatment, which is a legally binding document, if created properly and witnessed, where you can say that if I lose capacity or have an accident or an illness that takes away my communication or my mobility, I do not want to be ventilated. I do not want to be peg fed. And you can legally make this happen. But very, very few people do, because it's a difficult thing to do. But what we are encouraging people is to have conversations about the future, that concept of advanced care planning. And we will do less harm if we know what people's wishes are. Next slide, please. And just a couple of words on the concept of dignity, which Joe has already mentioned. One of my gurus is Professor Harvey Chochinov. Many of you will be familiar with his work. And his concept of dignity is about self-worth. How, as a patient, I want to be seen by my doctor or my nurse. And he gave a very powerful example when I heard him talk in Canada, probably 20 years ago, when he was introducing his dignity theory. He gave an example of a man very cachectic in bed, dying of HIV, of AIDS. He'd lost all of his body weight. He was skin and bones, but by his bed, he had a picture of himself as a bodybuilder, as a weightlifter. And he wanted to be seen as that man. He didn't want to be seen as skin and bones in bed. And when we go to see our patients, in order to make the right ethical decisions, we need to try and see people as they were, not as they are now. So next slide, please, Joe. These are just a few quotes about how misguided some of our modern medicine is before I quickly tell you about our case. Iona Heath is a retired London general practitioner, and she has written a lot about misguided modern medicine. And she suggests that our attempts to prolong life sometimes and cause more suffering is the wrong way to go about managing existential fears. And of course, we can stent every tube now. We can keep people alive for a very long time. And the question that we're asking today is, what should we do? Next slide. You may disagree. In hospital, you can only die when medical staff declare you can die. That's pretty provocative. Next slide. And yes, sorry, I've lost the reference. This was somebody called, I think, Jay Simpkin. She described that we've lost the concept of grayscale medicine and we've become very black and white, and that modern medicine has lost its patient-centeredness. So next slide. So I'm going to tell you about a patient called Avtar. He had complications of cancer that we can treat very easily. He had very persistent anemia from his prostate cancer. He had recurrent high calcium, which of course we can treat, and he had multiple infections from a failing bone marrow. Next slide. So if we go back to Atul Gawande's questions, Avtar was 73. He had widespread prostate cancer, severe pain. He had had multiple transfusions, and he'd had his hypercalcemia treated twice by the time I met him. His biggest fear, if we go back to those Gawande questions, was losing his mobility and becoming very dependent on others, particularly around toileting. His goal of care, if he felt better, was to stay at home with his family. He didn't want to go into the hospice or the hospital, and he wanted to live long enough to be at his daughter's wedding. In terms of bargaining and trade-off, he did not want life at any cost if he was paralyzed. But he goes on to develop spinal cord compression and pressure ulcers. Next slide. So in our consultation with Avtar, I knew that he wanted to stay at home, but he did need carers to visit and help his family to care for him as he became less mobile. His absolute priority was to have his pain controlled. And we talked to him about appropriate options. Once he developed spinal cord compression, he started to talk about not wanting to live more. I knew I could prolong his life with multiple transfusions and repeated admissions to treat his calcium. But he agreed to one more transfusion to help him live to go to his daughter's wedding, which was in a couple of weeks' time. His hemoglobin was very low by then. He did attend his daughter's wedding in a wheelchair. His paralysis was pretty complete by now. His daughter was married, and in the weeks following the wedding, his calcium started to rise again. And at that stage, many doctors would have admitted him and treated his calcium again. But we had that conversation and decided between us, between him and the healthcare team and his family that it wasn't the right thing to treat his calcium again. So in the language that we don't want to use, we withheld that treatment, but it was the right thing for him. And he died very peacefully with some sedation and analgesia just about 7 days later. And that's the case I want to share with you. And I'm going to hand back to Jo now.
Thank you very much, Ros. So the case study that I am going to present, similarly, I'm going to give my own very, very worthy nod to Atal Gawande, because I have to say, of the many, many books and lectures and so on that I have read and listened to in my career as a palliative nurse, I do think that this book, Being Mortal, if you haven't read it, I really would strongly suggest that you do, because it really has profoundly influenced me in my career. So I'm going to talk to you about a lady whose name is Val. And Val was an 82-year-old lady who I met actually not at a hospice, but in a nursing home that has some palliative care beds and very, very excellent palliative care provision within it, with a really very strong multidisciplinary team. Val was an 82-year-old lady, and she had been sadly diagnosed about a year before I met her with motor neurone disease, and had actually been doing really fairly well initially at home. She was widowed. She had one daughter who lived nearby, and very importantly, a daughter who lived very far away from her, who spent a lot of time sort of on FaceTime and telephone, but actually didn't see her mum face to face very much. And I think that is actually very relevant to this case study. By the time I met Val, she had sadly, her motor neurone disease had really, really picked up in terms of its progression. And she was beginning to lose a lot of her strength and her swallow. And she had a lot of problems with secretions. She was still able to speak, make herself very clearly understood, although her voice was becoming weaker and weaker. And Val decided that she would get herself admitted into this care home, which was near to the daughter that she saw very regularly. And her understanding of her condition when she first came to the nursing home was that she was absolutely aware that she was now very likely to be in the final weeks of her motor neurone disease. She had had amazing support through, we're very lucky in the area in which I work, there is an absolutely excellent clinical nurse and neurology nurse specialist in motor neurone disease, who had helped Val throughout her diagnosis to sort of understand what the likely trajectory and experiences of this disease would be. So she was aware of her prognosis. What she was the most fearful of was going back into hospital. She had spent a good few weeks in and out with an aspiration pneumonia in particular, and she was absolutely fed up. She just couldn't bear the whole hospital experience. This was also during lockdown, so hospital experiences, as one can imagine, was particularly difficult at the time, with the lack of visiting and so on. Val was a widow, but she had been very happily married for a very, very long time. And she and her husband had traveled extensively, particularly in Europe. And so one of her goals and her priorities for the rest of her life was that she wanted to reminisce. She wanted to look at photograph albums full of pictures of her and her husband on holiday. And actually, we kind of trumped that. And we did some virtual reality with Val. We took her back to Florence, which was the city that she loved most dearly of everywhere in Europe. If any of you have got access to virtual reality, and if you ever have the opportunity to use it with patients, I know that Ros and I both have got some really, really special memories of how profoundly moving and enjoyable this can be. I remember she and I once watched a daughter and her mother go via virtual reality back to an ice cream shop somewhere in Scotland that the mum used to take the daughter to when she was little. Very, very happy, special things. So Val, ostensibly, when she came to this nursing home, she was absolutely clear of what she wanted: to have some happy times. She was absolutely clear about what outcomes she would find unacceptable and what her trade-offs were, what her compromises were. She was determined that she did not want to suffer in a prolonged way. She knew what was going to happen in terms of her motor neurone disease with her breathing. Her secretions were particularly difficult for her already. She was prepared, therefore, to sacrifice some length of life if that meant that she were struggling to breathe, unable to communicate, and so on. She was very, very clear about that. What the problem with Val was that her daughter, the one who lived far away from her, who therefore hadn't sort of been in the same room and actually seen what was going on in terms of the deterioration, could not understand why Val had made it very clear that she was under no circumstances going to agree to have any form of artificial feeding via a peg tube. The daughter who lived nearby could understand that and could collude with the concept that quality of life was about a more gentle approach to living. But this other daughter, whenever she was on the phone, whenever there was any screen time, the conversation morphed into yet another pleading of this daughter for her mother to go, before it was too late, to go and have a peg fitted, because her daughter couldn't bear the concept of her mother dying and felt that her mother would be dying starving. She had all these awful imagery in her head of what would happen. But Val was very, very clear that that is not what she wanted. And whilst Val had she didn't actually do an ADRT, which Ros was just describing, an advanced decision to refuse treatment, she did remain capacitous, and she was very clear that she was not prepared to have a peg tube. And I'm very interested in this concept of food towards the end of life. So whether that is food, people being able to swallow a little bit, or via a tube, a peg, or an NG, particularly a peg. There was an interesting article written, it's quite old now, by somebody called Julie Ellis back in 2010, called Family Food Practices. And actually, her concept of food is a subset of a larger piece of research that she was doing into everyday life during life-threatening illnesses. And she comes up with these concepts of food talk and food fights. So food talk being that, and I think we can all hear it so often. We can hear when somebody comes to visit their loved one in a hospice, they'll ask the nurse, has mum had much to eat today? I know as a nurse, it's the first thing I'm interested in about, well, not the first, but certainly something I'm interested in about my patients. And we can judge so much about where somebody is in their illness, especially when we're caring for people who are elderly and frail, about how much oral intake, how many calories they are ingesting. So food talk, food fight can be a positive thing. It can provide a focus of conversation, food talk can. But then there is this other concept that Julie Ellis comes up with, which is food fight. And that is certainly what happened with Val and her distant daughter, is that this whole concept of food became their battleground. Val saying, no, it is not life come what may. It is not that. It is my quality of life. I don't want to have more fluid on board. I don't want more secretion. I don't want to have my life prolonged when my life with motor neurone disease will not be a life that I consider conducive to quality and dignity. And the concept of food fight is again interestingly observed during this research of Julie Ellis's. She first of all talks about that food is equated with the gift of life, and we all know that as a newborn baby is born, the first thing that happens is that baby is fed by its mother. The food is a temptation to life. If somebody eats a little bit more, they're tempted to have a little bit more life. That there was this interesting concept of the measurement of food constitutes a measurement of life. And in this research, Julie Ellis talks about a wife who watches how much whiskey her husband drinks in a day. Her husband is dying, and hopes that the bottle of whiskey will last until Christmas. And if that's the case, her husband will still be alive for Christmas. So this really, really interesting measurement of increments of life and food. But of course, tensions can arise around food. There was one thing in the research around the fact that one wife who had always looked after her husband, a traditional housewife, his food was on the table when he came back from work every day, and how offended she was that at the end of his life, she didn't want his food, but would eat these little things that the hospice chef had prepared. So we know that food constitutes pleasure, but it can represent conflict within family. And certainly that was the case with Val. And Val's daughter. So as I say, what happened to Val is that Val did come to our nursing home, and she was supported by a lot of people, but she was very, very consistent that under no circumstances would she consider not only a PEG food, but indeed no subcutaneous fluids, certainly no intravenous fluids. She wanted to have her secretions managed as well as she could. And although, as many of you will know, having cared for people with motor neurone disease, that can be in itself an enormous challenge, actually the fact that as the end of her life drew nearer and she was more dry, they were less difficult to manage. And we did manage, I'm delighted to say to you, to have some lovely conversations with Val's daughter, and for Val's daughter to understand that the appropriate option for Val was to, as I say, we're not going to use the word withhold or withdraw, certainly no withdrawal, but was not to go down this route that was medically and technologically fussy and not what Val wanted. And her daughter, when she came to see her more and actually spent more time physically in a room, I think she then became more accepting that quality of life most certainly trumped the burden of a quantity of life. And Val was with us for 8 lovely weeks. And I'm delighted to say that she died with both of her daughters in her room, with music playing and reminiscing on a happy life. So that's the end of my case study. I think I'm now going to hand back to you, Ros.
Yes, have we missed one slide, Jo? Maybe we haven't. No, okay. Next slide. So we're just going to finish with a couple of quotes that have influenced me in my career. Many people talk about dying with dignity, and I hope that we've shared 2 cases where we felt that dignity was upheld for our 2 patients, mainly because we valued their decisions and what was of value to them in their life. But this is actually, I think David Roy, not David Barnard, was the author of this quote back in 1988. He was a bioethicist in Canada, and his model of dying with dignity was dying without a frantic technical fuss. And I think possibly in our next presentation, we're going to hear a bit about frantic technical fuss. Certainly, I've been lucky enough to work briefly in Calcutta and do some teaching. And I did see quite a lot of frantic technical fuss for people with very, very advanced cancer in intensive care who possibly shouldn't have been there. Dying with dignity is about dying without severe pain that ties up one's consciousness and leaves one free for nothing and no one. For me, priority is managing pain. And dying in the presence of people who know how to drop the professional mask. And I think that's a challenge for some of us. It's certainly a challenge for some of the doctors that I work with, but patients value it when we drop our professional mask. Next slide. Sorry about that buzz. Okay, this is, if we had longer, I would talk to you about this painting. It's called The Hug. It's by an American artist who died of lymphoma. And it's a really interesting painting. You can't really tell who the patient and who the family member or whoever's hugging him is. But what you can see is it was the logo of the American Palliative Care Association. And it's trying to convey physical, emotional, and spiritual care. And you can see that there's almost the drip stand is almost a cross if you look carefully. And so there's the emotional hug, and there's the transfusion or the drip, and then there's the spiritual cross. So we put it to you that palliative care is more about relationships, which we've talked about today, not interventions. Next slide, please. We're coming to the end now. Another guru of mine, and I think of Joe, is Professor Balfour Mount from Canada. This is a great paper where he talks about much of what we've talked about today, how we can help our patients move from suffering to well-being, even though they are not going to be cured. And lastly, the last word, whenever Joe and I speak, always goes to Dame Cicely Saunders, who I think we all agree founded the modern hospice movement. How people die remains in the memory of those who live on. And our role in palliative care is to create better memories for families who are going to live on. Thank you.
Thank you, Rose and Joe, specifically those wonderful stories through which you took us, which conveyed a lot of in-depth messages that we all need to think every time we approach patients who are on the field. And there were comments in the chat telling that very much enlightening. And yes, we'll be sharing the video link in the group so that they all can go back and listen whenever they want to go again. Thank you so much, both of you. We'll take up more questions after Dr. Raj's presentation. We'll take up questions too.
I will share just a moment.
Yes, sir.
How does one share? From Joe and Ross, and I was very fascinated. I have a conflict of interest to declare. I've been an advocate for end-of-life care improvement in India for the last 20 odd years. And that's my conflict of interest, and that's been an obsession sort of thing. And I've been also inspired by two ladies, Dame Cicely Saunders and Elizabeth Kubler-Ross, who started this attention to suffering of people admitted for cancer in the US, and Atul Gawande. So I share your interests, and I deeply share the values that you projected in the last half hour. So I am not calling it withdrawal and withholding. I too have a problem with the term. Limitation of treatment is also not satisfactory. Maybe limitation of treatment rather than limitation of care. Care continues. Treatment may be limited. If we were to treat thoughtfully and wisely. I'll give you an Indian perspective. You see, in end-of-life care in this area of palliative care, dealing with the dying, UK is right up there. I think it's number one in the world. And India has a lot of catching up to do. It is quite closer to the bottom. There's a reason, because I think technological care has come in much later to India, and especially critical care, intensive care has been about 15 years behind in being introduced to India. So the romance of curative treatment lingered that much longer and is still lingering. And the problems presented by heavily technological care, what you can do and what should do, that query, that question is beginning to bother us, but it has not taken root enough to be expressed by the bedside. I'll give you a case example. Okay? It's got a lot of Indian flavor. There's a 102 years old. We don't know for sure the age, as it often happens with these holy men. We don't know when they were born, said to be this sort of age, and long invalidism due to interstitial pulmonary fibrosis. Okay, disease which doesn't take longer than 4 or 5 years to bring the end, but he lasted 7 years with home oxygen, was quite dependent on his attendants. Now worse, over a few months, and I was called in to see him. Refractory to standard therapies. He was quite breathless when I saw him. It was really difficult to engage him in any conversation about what he wanted or didn't want. And you see, there are huge cultural variations in how to treat the dying, especially in a critical care environment across the world. It's even across a country like USA. It may be even highly varying across ethnic groups and highly varying across jurisdictions, as we see in the US. This elderly gentleman had a large following, thousands and thousands of followers, as it happens in the holy cities or pilgrimage sites of India, and many of them doctors. There are hundreds of doctors who followed his talks, his sermons, and when I talked to them, because they were the care, they're the next friend, so to speak. He having relinquished his family and other blood relations. They insisted on taking him to the hospital, despite all my argument to the contrary, and despite our team speaking to the followers. He was not benefiting from non-invasive ventilation. So there was no advanced care planning as you would want in an ideal world. You see, the acceptance of death and dying and what can be done and should be done is not well established in the cultural milieu of India. So this didn't really sink in, and the treating team was never for any intubation, but that wasn't acceptable. There was a visceral denial of his death and visceral denial of anything that suggested not treating. So repeated sessions of communications having failed, we had to address these questions. Now, these questions are addressed to people who are working in the Indian setting, and they have to ask themselves this closed question: what would you do in this scenario? Would you intubate and ventilate and provide full support till the end? I'm sorry to say, and even in this context, I have to ask this question because it's commonly practiced. It's still this what do you call it, frenetic or frantic technological fuss that you said is the norm, unfortunately. De-escalate treatment unilaterally. Now, you see, this kind of paternalism also still lingers, although the world is moving less and less, moving away from this paternalism, moving more and more towards an even relationship. Of course, it's not perfect, but it is even more pronounced. This power equations still are very marked, very pronounced in this part of the world. So do a slow code, CPR, cheat yourself. Would you do that? This is also being practiced. Nudge, nudge, wink, wink, stop what you're doing, but pretend you're doing, this sort of thing. The last one, which is the most difficult, and in the Indian setting, this is the reality, that you're unable to negotiate with a family for a reasonable solution most of the time because of family factors, cultural factors, because of physician factors. Physicians themselves have a problem facing up to death and dying, and facing up to this moral, ethical dilemma of to ventilate or not to ventilate, to support with life support technologies or not. So we negotiated. It was difficult conversation. So as it happens, when you have a tension, then you find a common ground and move forward. We decided on a time-limited trial. I said, all right, if you so insist, we'll intubate him, but we'll give ourselves 48 hours. Things are doing more harm than good, then we should stop. We should withdraw. Withdrawal is even a bigger intimidating term psychologically in India than perhaps in the UK or in many of the countries where end-of-life care is better developed. Well, we did not have an option. If you had to give a trial of treatment, then you have to have the option of withdrawal. That is why it is ethically and legally correct to equate the two, even though psychologically they may be different. They may be culturally differently viewed, yet practically on the ground, for professional reasons, we must insist that they are equal. Otherwise, you won't have a way out after a trial. And for many, if you didn't have the option of an intensive care trial, it would amount to under-treatment, because a lot of the time the situation falls in a gray zone and you don't know, you have to feel your way through. Then we took the decision after 48 hours. We took him back to the ashram, his own place, abode, where we extubated him and with anticipatory sedation and appropriate counseling of people around him and those who loved him. And then, very importantly, we broached on this subject in the Lancet Commission. The death ritual is so important. So death ritual could be accomplished properly. There's a way in which usually for a dying Hindu or one who's dead, he's cremated. But for a holy man or somebody of a spiritual personage, then that person actually is buried in this lotus posture. So that is supposed to be auspicious and the right way to give a send-off. So we could manage a culturally and religiously sensitive, completion of his story. So you can see this. This is a bit of a departure from the norm in India today. Ross, as you mentioned in Calcutta, you must have seen that time and again. This technological fuss in the end, no matter what age, no matter what the context is, because you don't seem to see another option. You don't see an option that is easily accomplished. But then, of course, it was difficult, but it was the right thing to do. You can see in India, these decisions are extremely difficult, while it is getting easier and easier in the rest of the world. You can see this comparison of Ethicus 1 and Ethicus 2 studies or by Charles Sprung and others across European ICUs. 15 years apart, they saw the treatment limitation decisions occurred significantly more often, 90% versus 70%. And then you can see withdrawals were more, withholding was more. At the same time, CPRs were less, failed CPRs were less, brain deaths were less. This is happening, but it's not so easy in India to take these decisions. You've got to be a champion of these issues and have to go against the grain, I should say. So time and again, I have insisted to my intensive care colleagues and other people in the medical world and to my students that medical decisions have to be a three-legged stool. Ethical, as Joe so eloquently showed us. And those 4 pillars have to be there. You have to go beyond the pillars, of course. It's not confined to the 4 pillars, but the 4 pillars have to be there in every decision. And you should try to marry all the 4 rather than emphasize one over the other. And that's where the skill is. And then there are the professional needs. That is, you have to be reasonably accurate in your judgment of where the patient's trajectory is. Apart from all the rest, that focusing on the person rather than disease. And then the legal principle, of course, everything has to be lawful. I'll come to that. But in India, after a long struggle over 20 years, we've come to a point when there is a legal sanction, there is a legal force to these decisions of treatment limitation. Because wherever I talk to doctors or other caregivers, they always ask this for one question. The suffering and pain is not the question. Cicely Saunders referred to the total pain. No, we're just looking only at the physical. Total pain has not sunk into the consciousness of the Indian physician or caregiver by and large. And then the question shifts immediately, whether it's legal or not, whether they'll get into trouble taking these decisions or not. That is one question that pervades every conversation on the subject. To that, my answer is yes. If you ask me 100 times, I would say yes. Why? On the basis of constitutional validation and common law. I had to get into law. I had to work with lawyers. I had to work with legal experts to be able to get this authenticated, that it is not legally invalid. There were not many case laws for a long time. I think the first one was in 2011. Prior to that, they touched upon right to life and those sort of issues, not really treatment limitation. But this is Aruna Schonborg. She had a brutal strangulation by someone who attempted rape. She was maybe in her early 20s, and then she became vegetative. And she was being cared for by the nurses. She was herself a nurse, so her fraternity cared for her in a Bombay hospital. And for 42 years, she remained in that state, in a vegetative state, and a social worker picked up our case in perhaps the 35th year of that state, and said a euthanasia should be permitted. See, terminology, words matter a lot. They didn't have the vocabulary to say limitation treatment or something else. The vocabulary was euthanasia. So euthanasia has a connotation which doesn't sit very well with the common mind, people's mind. It is to deprive her of the right to live, so to speak. So the argument went in this way, whether she had a right to live or otherwise. Yet and the context, what is the context was a vegetative state, not the usual state, not the usual scenario in an ICU. Yet the court ruled that passive euthanasia, again, there's a constriction, a cramping of the terminology. They could not see the range of things that constitute, stopping treatment or limiting treatment. So they accepted, in principle, passive euthanasia, that is withdrawal and withholding. If it is consented to by the next friend, as in her case, the nurses, her colleagues, former colleagues. The court distrusted both the caregiver and the family. They said they may not act in the best interest of the patient. So majority of the time in critical illness, you're having to deal with the family. You have to take proxy decisions. You work with the proxy. But this is extremely limiting for the medical profession, this sort of judgment, and they prescribed a court procedure. You have to go to the High Court to validate this. This is as expected. It was not actionable. It was not in any way workable. So not a single case was brought to the court for this purpose. So we had to go back to the drawing board, work again, fight again. In the meanwhile, the court disallowed advanced medical directives. So that was another problem. Why did they disallow? Again, the suspicion of the family, the possibility of foul play. Now, we had to again go to the court for establishing self-determination and the right to execute a valid advance will. The first of these landmark judgments by the Supreme Court was in 2017, which is a right to privacy. See, the right to life had not been identified to be inclusive of right to privacy. Then this judgment established that right. So important. So the privacy of choice as applying to medical treatment is a corollary of this judgment. The most important judgment that was game changer was this common cause versus the Union of India. So this was for establishing the right for advanced medical directives, that is re-establishing the inalienable right of autonomy, and therefore autonomy being operative even if you lose capacity, therefore advanced medical directive can be executed, and therefore it followed that withdrawal withholding decisions were also valid constitutionally, and in case they haven't executed an AMD, or patient cannot have the competence to participate in the decision making, then the best interest argument should be used to enter into a conversation with the two stakeholders, that is the physician on one side and family on the other, and take a decision together, not unilaterally. It should be a collegiate decision, that is, the multiple physicians, not unilateral, at least 3, and it should involve the family. So this sort of, we finally arrived at what we wanted. And but where we lost the way was the Supreme Court took it upon itself to lay down guidelines for the implementation of AMD. So our troubles and the barriers were not over, they took a different shape. Now, there was problem amongst the caregiving professions that we could be foreclosing options to sue. We could be under-treating patients if we jump to the conclusion, and it would be a self-fulfilling prophecy if you If you think the patient is going to die and you take a treatment limiting decision, then that's going to happen. So then we were worried about the right to live, and the suicide laws still exist in India. So these were the worries. And then the presumption of untrustworthiness by the Supreme Court judgment, that there was a possibility of misuse by family and professional caregivers. See, most of intensive care is in the private sector in India, 80%. So there is conflict of interest. It's it doesn't have a system akin to NHS, where that factor is excluded of financial interest. So these were the problems, perceived legal vulnerabilities for the professional. Am I legally liable? So the answer to that is, even if we didn't go through the court procedure, there is a common law where consent is mandatory before any treatment of any sort, whether emergent, non-emergent, life-saving or not. So the common law right to protecting bodily integrity exists. And then if you violate this, then you are liable to trespass. So all this, we worked together with the legal experts and worked out these arguments. Now there's no criminal liability because there is, a properly made decision to withdraw or withhold does not constitute illegal omission. It's not founded upon intent to cause death. And then there is an Indian Penal Code also protecting, in case you, with the consent of the family or the patient, you undertake an action which you can predict will end in death, it protects you. So on and so forth. These we found out from our existing laws, but active euthanasia and medical assistance in death constitutes murder under the section 300 of Indian Penal Code. So we are not touching that now, because the basic principle of appropriate care to the patient, appropriate staying of the hand for instituting technologically frenetic fussy care. So that sort of thing. So the Supreme Court's prescription for implementing the common cause judgment was really fraught. For executing an advance directive, you need a signature of the jurisdictional magistrate of the first class, which is often extremely difficult for an elderly person. You don't have the wherewithal. Then the copies have to be sent to various places and so on. And there are three-tiered decision-making. There has to be a local committee, ethics committee in the hospital, and then they are answerable to there is a district magistrate you are answerable to, and then somebody physically comes, the judicial magistrate of the first class, to verify what is happening on the ground. So these are not implementable. And we have raised our objection very strongly. And we have said that all those scenarios which constitute the usual day-to-day practice in the intensive care does not become amenable to have a decision through this route at all. Perhaps of chronic vegetative state. Even then, no one has the energy to go to court. Not doctors, not families. So what we have argued is circumstances not considered in statute law is subject to common law. So we want to cleave to the common law provisions. And we don't have to go through the Supreme Court. So the vexed issue of the law is this constitutionally valid. And you're obliged to uphold autonomy and privacy in the best interest of the patient. Yet the procedure hampers practice. See what I mean? So this is where we are. We've argued that there are precedents in the US validating the lawfulness of withdrawal withholding in specific circumstances, and there are legislations around the world in 17 or 18 countries. The copious data of foregoing of life support decisions on the ICUs, and medical assistance in death is allowed where autonomy is accorded, respect as far as it can go. And the Indian data is sparse. You can see the meta-analysis published in the intensive care medicine. You can see that the black bars are the withdrawals, the gray bars are the withholding, and withdrawal is quite high. Withdrawal is close to 50% or more in most countries, except Israel, of course, where there's a problem, technical issue. But in India, withdrawal is often either frowned upon or people are too scared to implement. So how do we translate the law on the ground? I've been practicing intensive care, and I do very regularly take these decisions of withdrawal withholding, and well documented and published as well. And I have not been subjected to any legal action so far. See, following the spirit of the law is more important, I think. And a collegiate decision-making, shared decision-making, which are the principles that the court has highlighted, we should follow, and we should document honestly and meticulously. So refusal of consent is the basis on which we are taking these decisions. The family or proxy on behalf of the patient refuses consent for either instituting a life support system or continuation of the life support system. So their withdrawal withholding are similar, because withdrawal is actually not continuing, rather than pulling out. So the duty of care to respect autonomy and privacy has been highlighted by us, and then we have highlighted the precedents and practices across the world. So consensus standards of care exist now. We built a body of consensus. The worldwide position statements are there. Indian position statements are there from all these societies: Indian Society of Critical Care Medicine, Indian Association of Palliative Care, Indian Association of Pediatrics, and then there are recent publication guidelines from other institutions. Federation of Indian Council, of Industry, and end of life in India task force, end of life care improvement in India task force, of which I am chairman. The blue maple is of an institution called Manipal Group of Hospitals. ICMR is Indian Council of Medical Research and All India Institute of Medical Sciences. All these have their institutional guidelines. Now, end-of-life care in India, a model legal framework was made by the Vidi Center for Legal Policy, which is a legal think tank which advises the government. And this was developed with consensus across multiple professions and with consultations in several parts of the country. So this publication was with two societies which are deeply concerned in this area: Indian Society of Critical Care Medicine and Indian Association of Palliative Care, jointly prepared the statement to come together to care for the dying in India. And then this has got 14 steps for medical decision making, 4 or 5 of which are dedicated to palliative care steps. So if you have on the ground by the bedside, there are 10 situations which can trigger a conversation for end of life care. What happens is most people, they gravitate to a hospital or an intensive care unit. Whoever is dying, the family brings them to the intensive care unit. That's the default action. If you don't have the money, if you don't have the resources, that's the paradox. Either you have the resources and you have to die in an ICU. If you don't have the resources, you die anyway miserably without adequate palliative care. So this is what was highlighted by the Lancet Commission as well. It's the paradox we are facing every day in India. So all these situations, and the last one, would I be surprised? You know, the surprise question. Would I be surprised if the patient were not alive in 6 months to a year? These questions have to be asked by the bedside on your round. I mean, pulling yourself back a little bit, looking at the patient as a person and asking yourself these questions may let you, into a conversation with the family, touching upon the patient's values, touching upon the patient as a person, and setting goals of care and all. The FICCI illicit guideline gives this decision-making flow chart. If you're competent, then you have to deal with the patient gently, directly. That is exception rather than the rule. But if incompetent, not having an AMD, then you engage with the family. So the most crucial intervention is the family conversations, which we have to train for and improve and become effective. So a shared decision-making model is what we are advocating. And then implementing withdrawal withholding decision with adequate switch over to palliative care. So, there's between the black and the white, there are various shades of gray where we usually come in. It can't be total autonomy or total paternalism. It has to be a marriage of the two. It has to be marriage of all the 4 pillars that Joe showed us. There has to be justice as well, fairness as well. And then the crucial intervention, which is a multidisciplinary family meeting, is, these are the principles which you're following and advocating. The first meeting should be early, and all the different departments engaged with the patient care should participate. As Sridevi said, the nurses are not participating enough. We are not sort of engaging them enough. And this is something for to improve on and reform. Pre-meeting with colleagues, driving a consensus, very important intervention. Meet in a room more formally and have a structured meeting and use these mnemonics which have been well established and debrief the team once you're done with the family meeting. So you can see that the surveys on how end-of-life care is happening in India is very stark. You can see that the two point prevalence studies, 8 years apart, conducted by the Indian Society of Critical Care Medicine across 124 Indian ICUs, large numbers, 4,000. Mostly they are in private sector, as I told you. And then what is very striking is that 70% of the deaths have no treatment limitation, and the other 30% is actually not through treatment limitation, but they are called terminal discharges. Actually, there's a term called left against medical advice. So you get the family to sign a document which says, I'm leaving against medical advice, and therefore it absolves the treating team of any legal liability of treatment withdrawal. And then there is no obligation to ensure proper care of the dying person at home or elsewhere. So it's a pernicious practice that violates basic ethical tenets. And it's like washing your hands off the patient's care, which is the last thing you want to do. The last thing you want to do is display any evidence of abandonment. You don't want it seen so starkly. You don't even want that thought to occur in your own mind. There is no attempt to address the issues of foregoing of life support or dignity in death. Only a crude attempt to escape the legal liabilities. So it's a very selfish. It's not a patient-centered decision or family-centered decision. It's a self-centered decision. So we are advocating strongly against these practices. The patient and family are left to be fate to deal with the dying process without any psychological support or even physical support. So there was one publicized, highly publicized case where a patient was sent lama and the child died, the ambulance, and there's a litigation for huge compensation. So this doesn't protect anybody. It is just on paper. Actually, it doesn't. Since the Common Court judgment, we have been campaigning, filing an application for clarification, simplification. The Supreme Court has come up for hearing now. Can be the next couple of weeks or so. So the Illicit and the Vidhi Center for Legal Policy have drafted and published this model legal framework, which will perhaps be tabled in the Supreme Court. Do not attempt resuscitation is another big question mark in India. It is equated with active euthanasia. But then with the ICMR, Indian Council of Medical Research, we produced a paper, and now there's a statutory body, which is, and we got a publication. DNR is valid in India. We got a consensus guidelines. We were very much inspired by the DNA CPR document in the UK by the Resuscitation Council. And so I want to end here by saying that foregoing of life support, call it what you will, limitation of treatment or treating wisely decisions, need open communication, shared decision making, transparency, building of trust, and a quality palliative care should replace. Palliative care is, as a specialty, is on the ascendance in India. I'm so pleased with that development. It helps this cause. Although palliative care is not just about EOLC, but EOLC is a very important part of it. And the landmark cases in the Supreme Court have helped our cause. However, a lot needs to be done, because there are problematic procedures laid down by the court, which we are fighting for clarification. Professional bodies have laid out pragmatic procedural guidelines in line with the rest of the world, and I hope the interest of humanity, we succeed. Thank you very much for your patience hearing.
Thank you so much, Dr. Raj. I think every time when I hear, there are a lot more perspectives that you bring in each of your lectures. Thank you so much. I'm not taking too much time in sharing what I felt during the presentation, but I'll give it to the participants. If there are any questions, you can please unmute yourself, or just if you want to share your experience. I know that many of you are involved in palliative care in your own institutions, and you might be people who will be dealing with your colleagues on a daily basis for advocating whatever we have been discussing. So we would like to hear from you, either your thoughts, comments, or questions. Wait for a few minutes for the chat. While we are getting chats or questions, I just feel like when, as a part of advocacy, when we talk to medical professionals on one side and the public on the other side, I think it's always medical professionals always tend to say that if you don't do this, then you'll be sued. They don't understand when we talk about, they exist on many interventions, but on the other side, when we talk to public about advanced care planning or not to go for futile interventions, they say that, but the doctors insisted. So this is something which I found very interesting, that most often they put the blame on the other party. I'm not sure whether that's the same for you and any questions from the participants?
I've got a question for Dr. Raj.
Yes, please.
thank you very much. It seems very complicated, the legal position in India, but I just wondered, have any doctors been recently prosecuted for stopping ventilation in somebody where it would be futile to continue? I'm glad you haven't, but are there prosecutions happening?
No one. Actually,
one.
it's all in the mind. I mean, you have a barrier in the mind for and the fear in the mind. In fact, there have been prosecutions for keeping a patient on a ventilator in spite of
Too
brain
long.
death.
Okay.
In spite
Wow.
of brain death.
Yes.
So we have to overcome these notional barriers that is also there amongst the profession. They are not actual. There's not any case of this kind.
Yes, and it does seem very complicated to do a legal advance directive in India involving judges. That is much more simple in England, even though very few people are taking advantage of doing one. Thank you.
I think there is one question for Dr. Raj. It's about LAMA. It's very common in many of the hospitals. Is it not legally right? So the question was to you about LAMA, whether it is legally right.
Sridevi, what's the question about LAMA?
Is it legally right or not? Because it's a very common way in many hospitals.
You see, Joe started with ethics and morality, and Ross highlighted the sufferings and what, to the lengths they go. They even created a virtual Florence, imagine. Now, where are we? Now, we are stuck with our with the problem of legality, which is only with a self-preserving instinct. It is not for preserving the dignity of your patient. So I want to ask the question back: what is our centrality of what is our focus? It is patient suffering, which is what our primary concern should be. So LAMA is actually relinquishing your moral obligations. So whether it's legal or not is a secondary question to me. Firstly, you have not fulfilled your role. If you've done that, your role is supposed to be caring. What else is it? It's not tinkering with medicines. It's not putting lines. It's not putting somebody on a ventilator. Primarily, it is caring. And these are tools which you may or may not use depending on the situation. So LAMA has got nothing to commend it. As I said, it's a pernicious practice we must follow. We must firstly let go of LAMA. I let go of LAMA years ago. None the worse for it. I sleep better. I feel like a caregiver. Okay, I'm not pretending to be one. I feel like one. Yeah, a big difference.
That's a great response, sir. I think taking from Joe and Moses, starting with the term how wrong it is being like withdrawal and or withholding, both is the moment we start using those terms, I think we are putting them into a great way of guilt that I'm not providing something which needs to be provided, or I'm taking away something from my loved one which I'm not supposed to do. So I think it's very important to not to use that terms, because the moment you start writing that in your records, then they feel, okay, doctor, let me think a little bit more. I don't want to take away, which may probably keep him or her alive. I think we have a lot to work on, Dr. Raj, starting from using the right terms, removing the wrong terms like passive euthanasia, I think from the dictionary of our.
We worked with ICMR on the terms used in end-of-life care, the 25 of them. So we redefined, we said we must stop using the term passive euthanasia. It's outdated. It's got a different connotation. Of course, we have to work on withdrawal withholding, as you all say. The next task would be to use a different term. Maybe we should call it appropriate withdrawal withholding. I don't know what. Maybe we should call it. I don't know. What are your terms that comes to your minds?
Appropriate options, that's what we suggested.
Appropriate options, yeah, exactly. Yeah. Allowing natural death is another one I used, but that I used only for DNAR. Maybe it's applicable more widely. Allowing natural death, A and D. That seemed to sit well with people.
Yes, but it hasn't been adopted. I also like it. And I often say, if you're dying outside in a cave, we wouldn't have tubes up, drips up, ventilators, allowing death to take place naturally. But I think what you mentioned, Dr. Raj, which is a skill that we don't all have, facilitating a good family meeting is a skill that all doctors and nurses need, not just palliative care doctors. And that's how we get a consensus within the family about the right way forward. But we call them care planning meetings in the hospice. But you have to be good at managing conflict. And every family I meet, there's always one person who doesn't agree with the option. That's very common. So the skills of facilitation, negotiation, and listening are so important. Thank you.
Thank you so much. I think there are more questions coming up in the chat. So I think we can wind up today's session. We have 5 minutes from the plan. So thank you so much. I'd like to say thanks to 3 of you for a wonderful discussion and stories which actually had a lot to think about in the coming days. And we'll be sharing the materials or resources and the recording so that people can actually go back and look at it again whenever they want to. They have some questions about it. Thank you.